Without any delay, I would like, before we begin our session, I'd like to give some small introduction. So of all the one who have joined this session, so starting with Dr. Uday Koirala from.
Namaste everyone. I am Dr. Uday Koirala. I am a senior consultant surgeon in Kathmandu Model Hospital and also chairman in Telemedicine Society of Nepal. So thank you for having this great event. Wish you all good luck. Thank you.
And Professor Dr. Sanjay Khadgi, please give us a short introduction.
Hello, good afternoon to everyone. I am Dr. Sanjay Khadgi. I am MD at Khadgi Institute of Endourology in Nepal. Well, I have been working in endourology for last 20 years.
Thank you, Dr. Khadgi. We are looking forward to hear from you. And Dr. Yakub, nice to see you also. Please give us a short introduction.
Thank you for having me. Good morning, good afternoon, everyone. I am Jakub Gajewski. I am from the Royal College of Surgeons in Ireland, in Dublin, where I live. But most of my work is in Malawi. I'm a social scientist, not a surgeon, not a doctor, an academic doctor, but I'm a researcher, full-time researcher, so I'll be presenting some parts of the research that we conduct in sub-Saharan Africa.
Okay, thank you. Looking forward to that also. Professor Moriyama, nice to see you also. So, sir, please.
Hi, nice to see you. This is Dr. Thomas Moriyama. I'm a medical doctor working for Kyushu University Hospital for long. And also I'm the chairman of a medical working group in APAN. So congratulations on holding the rural healthcare session today. So I'm sorry that I due to another appointment. I just joined the first 5 minutes, but I hope you enjoy the presentation and discussion. Thank you.
Thank you. Thank you for attending. Mr. Sanjay Paudel. Mr. Sanjay Paudel, are you there? Yeah.
Can you hear me?
Yes, you can. Go ahead. Please go ahead.
Yeah, hello everyone. This is Sanjay Paudel, working in the digital health since last 3 years. So I represent Sunday Computing as the lead of health information science. I'm so glad to be here. It's my third time that I'm presenting over the Japan, and the topic that I'll be covering today will be around the TPI and health infrastructure, mostly in economic space. So glad to be here and looking forward to learn more. Thank you.
Thank you, Doctor. Thank you, Mr. Sanjay. Miss Anusa Jayasri, please introduce yourself.
Yeah. Okay. Good afternoon, everyone. So I'm Dr. Anusha Jayasri we are from Sri Lanka.
Okay.
And I'm from the University of Visual and Performing Arts, and my fellow researcher is from the University of California. So, and we are very glad to do a presentation here. And thank you so much for giving us this opportunity. And I hope we can join these sessions in the future too. Thank you so much.
Yes, we are looking forward also. In future session also, we are hoping you can attend. So the next is Miss Kanchan Gautam.
Hello and good afternoon to everyone. I'm Kanchan Gautam. I am a registered nurse and now I'm a psychologist at. Am I not audible?
Yeah,
you can continue.
So I'm currently working at Dr. Iwamura Hospital, and I'm really delighted to be here and attending this session, and I'm looking forward for my presentation and learning from everyone.
Thank you, Kanchan. From Kyushu University.
Sorry, Matsuda from Chemdex. Nobody there. Sorry.
Okay, sure, no problem. Dr. Rosni Amatya. Can you give us a short introduction? Yeah.
Hello everyone. I'm Dr. Rosni Amatya. I'm from Nepal, but now I'm in Yokohama, attending APAN59.
Oh, so
And
okay.
yeah, by profession I'm obstetrician and gynecologist, but now I'm working in the area of public health in gender-based violence. Thank you.
Thank you very much. And Aruna Samarasinghe, Mr.
Hello.
Hello, yes.
Am I audible you?
Yes, of course.
Hello, I'm from Sri Lanka and I'm a student of the computer science honors degree in newspaper area and my supervisor is Anderson Jesse. And thank you.
Okay, thank you.
Professor Chakti.
Then finally, Professor Chang Ti Chuang. I hope I spell correctly.
Okay, hello, thank you everybody. This is Ti Zhuangjiang from National Taiwan University, and I'm very pleased to join this session, which we have a very good, wonderful time. Thank you.
Okay, so after this short introduction, we will begin with the session. This year, our theme for our this rural healthcare session is the cancer care. So because cancer is one of the most emerging diseases these days, since we are living longer, and also the incidence and the mortality of cancer is also getting higher. So there is slight changes. Since this is a cancer care, I'll give a brief only a brief introduction of what's the status and and so that the next presenter can follow their talk, because I'll give you the just brief review. My presentation is only a small cancer care status in rural cancer care. So I'd like to begin my presentation. So when we talk about cancer care in rural healthcare setting, I'd like to show you this picture. They say a picture speaks 1,000 words. This was a picture taken. This was the newspaper news published 2 days back in one of our newspaper. So they said like this is still the status of how the healthcare services are in remote areas. There's a transportation issues. People are still carried to the hospital like this. So this is the scenario in the most of the remote places in Nepal. So if you look at the cancer statistics in Nepal, there are almost about 22,000. This is the Globocon 2022 record. There are about 22,000 new cases, around 14,000 deaths, and prevalent is around 4,000. And if you look at the cancer burden in Nepal, the incidence, breast and the cervical cancer are among the top in the female, and also in the mortality also. In male, it's lung cancer and the stomach cancer. However, the census that provided here is usually most of the cases are missed or are lacking. We do have a cancer-based registry system which is gradually improving. So hopefully in future more cancer cases will be informed and registered. So talking about rural cancer care, it's basically it's a cancer care where the geography is very challenging, and it's very difficult to provide services in the rural cancer care. Why it matters? Because data have shown that rural residents face higher cancer mortality rates due to delayed diagnosis and treatment. So what are the challenges in rural cancer care? So basically main is the geographic location, isolation and the travel. It takes a long distance to travel to the specialized center. There's a limited transportation. There's a limited access to the specialized cancer center, and lack of oncologists and the specialized healthcare provider. Also, there is a financial constraint because of high poverty rate, high cost of travel and treatment and medications. And also there is a lack of adequate health insurance, making it difficult to afford cancer treatment and follow-up. And also there is some social stigmata. There is a lower health literacy stigmata around the cancer, and lack of cancer awareness about the prevention. And also the rural cancer survivor may face challenges in accessing long-term care, support services and rehabilitation process. All these leads to late diagnosis, poorer outcome and increased burden in the remote setting. So we do have strategies to improve cancer care, and hopefully like in today's session we will be hearing more about this, what are the different strategies to improve the cancer care in rural area, notably the telemedicine, which is getting very popular over the past few years, telemedicine and tele-oncology, where we can do a remotely consultation and follow up. Here at Kathmandu Model Hospital, we are actively like doing this telemedicine, and also our follow-up doing this telemedicine, and we can also bring the screening and diagnostic services to the rural communities. We organize health camps where we talk about and do screening of the cancer also, and we are also training local workers to provide education and support. And also we need to have a like a partnership with the remote the centers in the remote places with the center in the capital. And also we need to have a good financial support. There should be a proper mobile technology for delivering evidence-based treatment and support, and also rural people should also have access to the research, not only the people living in the urban areas. And also we should train and retain the healthcare profession at the rural areas. So there are various innovation like hub and spoke model center, patient navigation program, telepathology and remote diagnostic. And also we also need the help from the government, and also the grant and funding from the different organization, and also advocacy efforts. So here in Nepal there are various organizations who are working for the cancer, like Binay Tara and NCRS, Cancer Care Nepal, Nepal Cancer Support Group, and government initiative. So to conclude, rural cancer care face unique challenges, but it's improving through innovation and collaboration, and equitable cancer care is achievable with sustained effort. So with this like a brief introduction, I hope we will have a detailed discussion in this rural care in this session. Thank you. So we'd like to start our presentation proper. I'd like to request Dr. Yakub to start his presentation. The ECASI project in Malawi, a story for hope for breast cancer patient. Dr. Yakub was here in Nepal about, I think, last December. He attended one of our conference and also presented his work in our like a Society of Surgeons of Conference of Nepal. It's nice to see you again. Please, Dr. Yakub, you can go ahead.
Thank you very much for having me. It's a very big pleasure for me to be invited again and to share another story of related to our work in sub-Saharan Africa. This is a project that speaks to the many points that you raised about rural challenges in cancer care, and from another continent, from sub-Saharan Africa, from Malawi. We call it the story of hope, because when we started working in Malawi, we thought the situation was pretty hopeless, so we're kind of trying to plant little seeds for the majority of people who live in rural areas in that country. This is just a picture again to highlight how rural life looks like in sub-Saharan Africa. People live very basic lives. They have no access to water, no electricity. Very often times they just farm, and then that's what keeps them busy throughout the day. And the food is needed, consumed every day. They don't store any food. Also, they don't have access to basic means such as education, medical services, or like I said, even running water. So very basic life, and not many things to access in those areas. Moving on to the specificity of breast cancer in Malawi, is the third most common cancer in women. Very low survival rates, below half a year from the time of diagnosis. As we've already heard, is related to late presentation and late diagnosis, issues to access and things like that. Only less than 10 people out of 100, less than 10% of people survive beyond 18 months. And if you look at the statistics, the kind of modeling studies, the incidence of breast cancer is expected to move ahead of cervical cancer, which is currently the number one female cancer in sub-Saharan Africa, in the next 5 years. So there is a growing problem, but very little work that goes into addressing it. About the ACASI project, the word ACASI means a woman because it's a kind of a woman's health project. One of the areas is breast health, breast cancer. The goal of the project is really to downstage breast cancer in Malawi. If you look at the recommendations by the WHO, they say that screening programs in lower risk settings are not really recommended because they create a huge demand. If we start screening healthy people as well, then we might overload the currently weak healthcare system. So the recommended strategy is downstaging, which is basically picking people with as early as possible when they start experiencing symptoms related to breast cancer. In our project, we started because we are the only project in the country that works in breast cancer. There is, like I said, very little work that is being done to address this growing problem. We had kind of 3 levels of intervention, 3 strands of work in the project. So first of all, we wanted to assess the current healthcare sector's capacity for early diagnosis of breast cancer, and we wanted to identify barriers, opportunities to establish a national program because early on in the project, when we started to consult the government, the Ministry of Health, we found out that there is no specific document that relates to breast cancer health. There is no national breast cancer control plan or any similar document. And also in the country's cancer care plan, breast cancer was not really highlighted enough. It was just a short paragraph. Secondly, we also looked at kind of strengthening the services. So we wanted to develop a training in clinical breast examination because this is the only kind of a feasible means on detecting any breast abnormalities currently in Malawi. They don't have mammography, they don't have any other services, so CBE is the current practice, but there was very little done. So we wanted to improve that, but also, and very important, we wanted to reach out to people who are in those villages, to raise awareness and inform them about breast cancer, because oftentimes they did not even know that breast cancer could be something, they associated issues with the breast with witchcraft, with some sort of a higher force punishing women for not being good or, committing sins or things like that. So there was a lot of myths in the community, and that's why people did not want to show up, because first of all, they did not know there was something medically treatable. So there was a lot of work that we wanted to put into that. So we wanted to assess, we wanted to strengthen the system, and also improve awareness in the communities. So the first, I'll show you the highlight of our first objective, that we did a national kind of a study to look at all different areas of what services are currently available in Malawi, and I want to highlight 3 things. There was no specific plan for breast cancer when we started the project, in the country. Secondly, there was no pre or in-service training specific to breast cancer available in the country, which was a shocking discovery because we looked at the medical curriculum at the College of Medicine, and doctors, as they underwent the medical training, they did not have a course on breast cancer. So that is a gap that we identified as well. And thirdly, which was something that was also very, eye-opening. They had 2 breast clinics that were run by general surgeons, but one was open on Tuesday for 2 hours, and the other one was open on Wednesday in a hospital 400 kilometers away from the other one for 3 hours on a Wednesday. So there was only 5 hours of time that people get, in touch with a doctor or with a professional who knows about breast cancer for a week. So the population of Malawi is 21 million. So you can imagine, the situation. So we started to develop the training in the first place. And you can see a picture. We looked at with local general surgeons who kind of had a hands-on experience in handling breast cancer. We developed a 3-day course for frontline workers to kind of inform them about the essentials of breast health, detection of some breast abnormalities, and referral practices, because these are the people who live in those rural communities and then can refer people who have potential symptoms. They practice on mannequins, and then they also practice on real-life patients. So you can see another picture. This is the first kind of a cohort of people who underwent our training, and another kind of a thing that I want to highlight, we developed the first training manual on clinical breast examination for Malawi. It was just printed out last June, so kind of a very fresh document with a Ministry of Health logo, which is very nice for us. Thirdly, we also did a lot of work. You can see now on the picture that the work really in those, this is a picture of our communication, our awareness raising campaign. You can see the person lecturing, you know, she talks to males because these are the community leaders, these are the church leaders, the spiritual leaders in the country and people who actually have a say in those villages. So the message that we wanted to put across to them was, you know, when you see a woman with a, if you hear about a woman that has problems with her breast, do not associate it with witchcraft or any some sort of myths. She has a medical condition and she needs to be seen by a professional. So that's really the key message that we wanted to kind of impart to the local people, because then they were tasked with going out to the villages and say, look, has anyone had that problem? You know, we are here to help, and then we'll help you to go and get checked. So really the kind of aim of the outcomes of the project should lead to improve awareness of cancer rural communities, you know, so that's the main thing that we're working on. Improve utilization of health facilities, because there are quite a lot of health workers in Malawi, but they did not have any knowledge about breast health. So with the training that we developed, with the course that we developed, we can train people in the essentials of breast health. That should lead to improved functionality and effectiveness of the referral system. And ultimately, our big aim is to downstage and improve survival rates of breast cancer through those interventions. And that is really my 10 minutes presentation. So that's the work of the ACASI project. Thank you very much.
Thank you, Dr. Jakub. So, is there any question or query for Dr. Jakub from the audience? So next. So Dr. Jakub, like you were talking about those myths, people are scared to come forward. So how were you able to? It's also common in Nepal. Also, people are very scared to go and express their problem about the breast cancer. That's why whenever they come, it's already very advanced stage. So how were you able to change that myth in that population of yours? How were you able to convince the females to come and have a breast examinations?
Yeah, that's a very good question. Thank you for that. This is a complex problem and there is no easy answer to it. The strategy that we adopted was to work through a person who specializes in community engagement. So we developed a song or kind of something that, you know, in Malawi there is a lot of culture around music and dancing. So we developed a kind of a song about that. So people, I don't have the video with me, but it's like a dialogue that there is like a, you know, the lecturer, the person who gives the lecture sings and the people you know, sing together with her, and then they learn about breast cancer, and so that is about like a 1 hour, 2 hour session, and then there is a discussion that involves medical professional, nurses from the communities and things like people who have some that the community trusts. You know, that is very important. So the message does not come from us, for instance, from the outsiders, even from the surgeons themselves. The message about the kind of essentials of breast health and breast cancer risks comes from the people who are from within those communities. So I didn't have time, it was only 10 minutes, but I didn't have time to talk about the complexity of the project. So first we trained these people, and then we did the training with the local village chiefs and things like that. So we had a whole bunch of people who were trained in the key messages that need to go into those villages, and then we started doing the training with those people. So the trick really, I think the key to success is to not to go there yourself as an outsider, but really work through people who have the village's trust. And then, you know, they can, because I think that the good thing about our engagements with those people were like at the end of the session, people were like, oh yeah, we've seen that woman. Yes, we should have really helped her because we thought there was something wrong with her, but right now we understand that this is something that is medically treatable, that is just a disease. So, you know, that went quite okay, I think. but the key thing was that we had the local leaders involved from the very beginning.
Yeah, it's very important to diagnose breast cancer in early stage, because if you diagnose in stage 1, the survival is almost 99 to even 100% for the breast cancer.
Exactly. Yeah.
Thank you, Dr. Yakub. So if there is no further question, we'll move to our next presentation from Anusa Jayasri and Mr. Aruna Samarasinghe. They will be talking about predictive model to identify leprosy disease types using machine learning approach. Let's welcome them.
Yes, I'm audible you? Okay. Yes, I'm going to share the presentation. You all.
Slide case here.
Good afternoon, you all. Today we are going to present our presentation about our research topic. In this case, our research topic is to develop a predictive model to identify the leprosy with their types by using machine learning approach. And talking about the leprosy is a kind of a disease, and this disease can be affected to the various areas in the body and the intestine. And the main spreading point is the bacteria named called Microbacterium leprae. And talking about the leprosy disease, we have two major classifications in the world called rigidopterin classification and the WHO classification. And this research mainly based on the rigidopterin classification. And talking about the rigidopterin classification, we have 5 major categories. In this case, we have tuberculous leprosy, borderline tuberculous leprosy, borderline leprosy, borderline lepromatous leprosy, and finally we have lepromatous leprosy. In the talking about the current diagnosis method in Sri Lanka, we have traditional diagnosis methods like clinical diagnosis method and some doctor's diagnosis method, but the case is sometimes this diagnosis method have there are problems like time consuming. Sometimes, especially the people who are living in the rural areas, they can't access these accommodations without sometimes they have no money, sometimes they have no good transport facilities. They have to talk about problem statements. I already told you the leprosy is a kind of critical and dangerous situation, but the case is if you can identify leprosy in their early stages, definitely we can prevent the disability. And another case is the traditional diagnosis method have some problems and they are time consuming. Therefore, if we can provide some IT-based solution like by using machine learning or artificial intelligence, the way definitely there is some good things to the overcome on this problem. And talking about the objective of this research, the study the most common leprosy type in Sri Lanka based on rigidopterin classification and collect and develop a best data set to the train models and develop and train the model by using the convolutional neural network architecture basically, and evaluate the model by using the machine learning and the best evaluation criteria, and finally develop a web application to user-friendly, secure and efficiency web application to use the affected people to get their prediction. And talking about the significance of this research, we can provide accurate diagnosis result from using this web application. Not only that, people who are suffering for shy to this to talk these things to the and show this their affected areas to the another third party persons to give their predictions and move in the things, and they can know about that, and they can use this application and get their predictions by using themselves, and they can move to the prevention method. And another case is we can eliminate the hospital costs, hospital charges, and diagnosis report bills. And another case is we can use this type of solutions to control the leprosy spreading in Sri Lanka, also endemic regions, and also we can identify leprosy clusters in leprosy clusters like in Sri Lanka, not only Sri Lanka, but also another endemic region. And the talk about the literature review, we reviewed some literature papers. In this case, most of the leprosy studies goes on the WHO classification, and most of the things are using the convolutional neural network architecture with the publicly available data set. This is a summary of the literature review. And the data collection, these are some data images we collect from the Sri Lanka. In this case, we obtain all the leprosy images from the public health inspectors in Sri Lanka who are currently working with the anti-leprosy campaigns in Sri Lanka. And the main focus areas is Colombo, Davulla, Kurunayala, and Moratuwa. Because of these cases, according to anti-leprosy campaigns details in Sri Lanka, these areas is the most endemic regions in nowadays. And talking about this thing, and after the collect all the images, we divide these images into 5 major categories based on the European classification with the help of the dermatology doctor. And talking about the tools and technologies, we use Python, Google Collaborative Notebook, and some relevant Python libraries to our model development purposes. And we use fast HTML, CSS, and Java for our web development purposes. And we use Microsoft Word and the PowerPoint to our documentation runs. And talking about the experiment and result for data preprocessing, we use data cleaning, resizing, and splitting the data set to the training and testing validation thing. And for the model training purpose, we use convolutional neural network architecture basically, and with the pre-trained models. And for the validation things, we use accuracy precision recall and the underscore values. And for the development purpose, we developed a secured user-friendly and efficiency web application to use the features. And now we are going to test this web application in the model by using test data set. And talking about the experiment and validation purposes, we started our model development purpose with the convolutional neural network architecture to pre-trained models, and we use, in this case, we use VT19, VT16, inspection V3, and the tested 1-to-1 pre-trained models, basically convolutional neural network, and softmax activation function to our activation functions, and Adams optimizer to optimize our model performance. In this case, we use two learning rates with the 0.001 and the 0.0001. And the data, talking about data augmentation, we use data resizing, zooming, and the test data size, all the data sizes into 224 pixel size, and set that size to 32, and divide all sets to the training, testing, validation parts. In this case, you can see this is the accuracy-based results we got from our convolutional neural net with the pre-trained models. In this case, the best model performance goes to the VG16 pre-trained model. And the talk about web application purposes, we developed a user-friendly, efficient, and secure web application. In this case, our web application contains language selector. Therefore, user can select their own language, and we have chatbot feature, and we have high security data encryption method to encrypt our uploaded image with the symmetric encryption algorithm and the Farnet encryption algorithm with the cryptographic Python library. Because of sometimes the leprosy cases are affected to the people's private areas, therefore they worry about their privacy and the issues things. Therefore, don't worry about that. Our application have an encryption method. And talking about another case, users can get the information about our by using our web application with the what is the leprosy, how the leprosy spreading is happen, what are the leprosy symptoms, what are the leprosy types, and what is the sensitive test is the leprosy. Like this information, users can collect by using this web application. And these are the web application interfaces. And you can see we have what is the leprosy, what are the spreading leprosy, and this is the some kind of leprosy types, and what is the connection between the Ridley-Doppler classification and the WHO classification about the leprosy. We can get the like these answers, and this has a sensitivity test. In the Sri Lanka public health inspectors mostly use this sensitivity test to identify the leprosy patients, and these are the image processing part. In this case, patient first select their sensitivity level in the affected areas. We can select yes and no, and finally upload the image. And after upload the image, the model will check and process this image and give the answer. In this case, you can see this results can get the very informative way. In this case, we can get the idea about based on the Ridley-Doppler classification and the WHO classification with the percentage about the feature matching level to the image. And talking about the discussion of the conclusion, by using like this type of methods, we can improve the current diagnostic methods in Sri Lanka, not in Sri Lanka, but also in other countries. And the traditional diagnostic method, we can replace these things, and people who are suffering to try to tell these things to tell these things to the person, don't worry, they can use these things and get the prediction by themselves and move to the good treatment methods. And another case is we can by using this type of things, we can reduce the leprosy spreading, and we can identify the leprosy clusters in Sri Lanka. And talking about the challenges, the main challenges is the limited data set. If we can collect very lengthy data set, definitely we can come up with the better results with the compressed models. And we have a encryption method. Therefore, users do not worry about their privacy and the security issues. And talking about the future works, we hope to develop a better and the lengthy data set with the leprosy, with the more leprosy images, and we are going to use the very complex and more good models, machine learning models with the retained models or customizable models, and collab with them, these two, and we are going to come up with the better results and more user-friendly web application. And this is the end of my presentation. Thank you all for hearing my presentation attentively. Thank you.
Thank you, Dr. Aruna. So, if you have any query, like question for the presenter.
Hi, I did have a question. Thank you for your talk. I was wondering what the sensitivity of this model is when, the mode of photography changes, because I know for similar models that detect skin cancer, they're highly inaccurate if the lighting, if the angle of the camera, and all of those things don't necessarily line up with how the input data images look. And that can actually really reduce accuracy. And I was wondering if you considered that in your model.
Yes. Can you again ask it?
You are not able to hear Mr. Dr. Sonakshi was asking about the sensitivity of your like the application, because yes, because of the camera angle and also the
No, it is not the issue, because we are going to get the image and cut the image affected areas, and we train with these things, and we are remove the background effects and the things. Therefore, the model will get the images with the removing the background things and the background effects areas. Therefore, I think it's not the issue, and this is the thing.
Thank you.
Okay, thank you, Dr. Aruna. So I would also like to welcome Dr. Sonakshi Sharma from University of Nevada. Dr. Sonakshi, welcome to this session. So we are going ahead with the third presentation. I'd like to request Dr. Sanjay Khadgi to start his presentation on experience sharing of mini PCNL in Nepal. Dr. Sanjay Khadgi.
Well, good afternoon to everyone. First of all, I would like to thank APAN and Kathmandu Model Hospital for giving me this opportunity to talk on mini PCNL in Nepal. I think this topic is not appropriate in this June meeting. However, I will be sharing this one of the modality of the treatment of kidney stone of mini PCNL in Nepal. Well, mini PCNL is the modification of conventional PCNL with the use of miniaturized scope and the smaller track less than 20 frames, which was first performed by Hillel in 1997 and developed by Jackman in 1998 using 11 frame sheet in a pediatric population. If you see the guideline for the treatment of kidney stones, like it depends upon the size of the stone, but we don't see any word like mini PCNL. And however, if you see these days, there are several papers on mini PCNL because of its several advantages and outcomes. So we started this mini PCNL technique with the help of Professor Chen Guohua from China, who has the vast experience, and he has the largest number of papers in mini PCNL in the world. With his help, we could start mini PCNL from 2005. If you can see, note this date that we started mini PCNL technique in Nepal. So today I will be sharing you what this mini PCNL is, how these kidney stones are removed by with a minimally invasive technique. Here is a short video to demonstrate you. This is the case of 42 years male patient with the multiple stones in his right kidney. So I will be sharing you how this technique is done in our setup. We perform this mini PCNL under spinal anesthesia, as you can see here, because patient is only half anesthetized and patient is fully awake. This is our instrument table, as you can see here. Initially, after giving anesthesia, we place a ureteric catheter, that's a small tube placed in the kidney and the stone site. Then we turn this patient in prone position. In order to have a good setup, we need to have a good manpower and also a good setup to have a good outcome of the surgical outcome. So in our setup, after placement of a ureteric catheter, we turn this patient in prone position, which takes only 1 minute in our setup. Whereas if we perform this PCNL under general anesthesia, generally it takes 15 to 20 minutes, even more time consuming when we perform this technique under general anesthesia. Once the patient is turned in prone, as this is done under spinal anesthesia, we keep these two bolsters, one in the lower abdomen, as you can see here, and another is in the epigastrium region, in order to keep proper ventilation. We make this abdomen free so that patient can have easy respiration without any difficulty. So once the position being done, then we drap this patient under the fluoroscopy view. We just pass a needle to the desired calyx, as you can see here. It does not take much time, and this is completely a minimally invasive technique in order to remove this kidney stone. And once this needle is placed, we get a urine from the kidney, as you can see here. Then we place a guide wire of 0.035. It's a small guide wire. After placement of this guide wire, we make a track and we make a 5 millimeter scar, and we do dilatation starting with the 10 or 12 French and up to 20 French. As you can see here, that black one is, we call it sheet, axis sheet, and it's done gently, and with the help of telescope we can pass our scope inside the kidney and we can have a look inside the kidney. We remove this guide wire which was placed initially, then that is the stone, kidney stone. Mostly these are calcium oxalate stone, 80% of the cases. And through the telescope, as you can see here, we pass a lithoclast, it's an energy source, in order to break these stones, hard stones. We fragment them into multiple pieces with the telescope, with the ballistic lithoclast, as you can see here, and by irrigation we collect these stones in our hand, as you can see. These are basically calcium oxalate monohydrate, hard stone, black stone and hard. After the completion, as you can see here, complete removal is done. After the procedure, we check with the contrast to ensure the complete free of stone, and these are the only 5 mm scar, and these are the stones removed from the kidney. So patient can be discharged within 24 hours from the time of the surgery. So why it is becoming more and more popular in the world? So it is, number one, it is very cheap and stone clearance is much high. And the indication for mini PCNL is it can be performed in pediatric and any age group, failed ESWL and RARS, and stone for upper ureteric stone, large stone burden, stone in anomalous kidneys, and renal stones in several spinal deformities, and stone in solitary kidneys, and any calicial diverticular stone. Here are some of the examples. A very small boy who underwent mini PCNL. As you can see here, bilateral stone after the completion of the procedure, complete stone removal is done. And mini PCNL can be done for complex staghorn stone, as you can see here, bilateral staghorn stones, which were removed by mini PCNL technique. Even for the large upper ureteric stone, if you see here, after the procedure, complete removal was done, and also this mini PCNL, this is the 10,000 cases reported by our professor in Journal of Endourology in 2013. Complex renal stones can be performed by mini PCNL. As you can see here, two stages, first on the right and second on the left side with the complete removal of the stone. So mini PCNL can be performed in spinal deformities, as you can see here, who had kidney stones removed by mini PCNL technique. This is our own paper in the anomalous kidneys. This was the first paper in Journal of Urolithiasis, showing that stone-free rate is 90% in mini PCNL technique. This is the horseshoe kidney stones with the 4 tracks, and patient would be discharged in next day. Even patient with the spinal deformities like this, very challenging, can be performed mini PCNL technique. These are stones removed from one single kidney. And this is one of the largest stone we remove by the 6 tracts, and this is the post-operative pictures. These are the tubes through which all stones were removed by mini PCNL technique. Well, so this is our own paper published in Journal of Endourology, which has the highest impact factor, showing that 90% stone clearance. And our complication rate is 8.1%, out of which 7% fall in clavicula 1 and 2. That means the major complication is 1% in our hand. These are some of the international publications from our study in the Journal of Endourology and European Journal and Journal of Urolithiasis. So I conclude my talk that PCNL is safe and effective treatment for upper urinary tract stone with less morbidity. Thank you very much.
Thank you, Dr. Sanjay, for the wonderful presentation. For everyone in the audience, Dr. Sanjay Khadgi is the pioneer of PCNL in Nepal, and it's a wonderful to see your work. Thank you, sir. So, if you have any query from the audience. So, if none, we will move ahead. Thank you, Dr. Sanjay Khadgi. We'll move ahead with the next presentation from Mr. Sanjay Paudel. He will be presenting on DPI over digital health in Nepal. DPI भनेको डिजिटल
Hello.
Yes, we can hear you, Mr. Sanjay. You can go ahead.
Hello everyone, thank you again. It's me Sanjay Paudel, Digital Health and Public Infrastructure Practitioner. So glad to be here. Today, though the topic is around the cancer, but I think it's crucial to share the recent updates that what we're doing with Ministry of Health and the practice that we have been doing around the digital health public infrastructure. Basically, when we think about the data, there must be the robust public infrastructure, which is related to digital health infrastructure. And to create a proper evidence system, there has to be some standard approach wherein we have to technically and scientifically capture the clinical journey using the technology and tools, which refers to the digital public infrastructure, wherein we have to promote the inclusiveness and equitable access to the service delivery, which reflects the proper quality of care. Additionally, on top of the DPI, it's much important to emphasize the citizen-centric approach rather than the technology. There are a few of the components that is to be taken care of to identify the patient and to identify the citizen, which covers the national ID as the primary infrastructure, wherein all of the patient has to get the health ID as the functional ID, so that the continuity of the care becomes easy whenever there is the referral or identify the patient within any of the healthcare settings. Likewise, there are operational components wherein the payment has to be integrated to follow the universal health coverage, and also the better connectivity, so that the data has to be moved on from one healthcare facility to another healthcare facility, and also the use of the technology around the community health program is essential. So the data has to move from community health to facility, and likewise, and vice versa. So these are the parameters of the digital public infrastructure. Today, I will be mostly comparing what is the progress in DPI in Nepal in terms of the digital health infrastructure and the current practices along with the progress that we've been able to do within the Ministry of Health. So this is the architecture that Nepal has followed on with. This is the open framework wherein most of the DPI practitioners, around 80 plus countries, are following the same framework to be in the same phase and not to deviate with the global good practices. So if we compare with the current paradigm with the MOSP and Nepal government, the upper tier has the business domain services, wherein there are 4 underlying components. One of the component is missing, that is shared health record. We don't have the proper infrastructure for the shared health record. That's why we can't think about sharing the health record from one healthcare facility to another facility. So these are the building blocks. So first block is LMS, Logistic Management Information System, where all of the healthcare facilities in Nepal, they are using the centrally deployed Logistic Management Information System. And also to aggregate the information, DSIS is being used to all of the tier of the healthcare facilities. Other component is the insurance, where all of the service providers are using the same system. So in this one component is missing, that is shared health record that I mentioned, and which has to be the priority for MOSP, and also the Nepal government has to prioritize for that. Until and unless shared health record is not in place, we won't be able to share the information from one healthcare facility, or we won't be able to coordinate the referral system. So underlying component behind the business domain is the component layer. These are other blocks which we mention as the registries, national registries. So starting with the terminology services. So right now, for all the disease classification, ICD is being used, whereas the other component like National Health Data Dictionary, observational data that comes up from the pathological lab, and also community health program, all of the variables that we use in the community health program is not being standardized. So until and unless this all parameters doesn't get in standard in place, we won't be able to share the information. We won't be able to communicate with multiple providers. So in order to speak with the same language with the care providers, the terminology services has to be in place. Likewise, client registry as the health ID is the another component, along with the facility registry, health worker registry, and product catalog. So these are the underlying components where only four components are ready to be in use, but product catalog is not there in terms of the standards. So this is another missing point that we have to be in mindful when designing the electronic health record or national health information exchange platform. The third layer is the interoperability layer. This is still under discussion. So unless we have a clear roadmap how we are going to share the information within the healthcare facility, or unless there is no policy within the national health data sharing policy, we won't be able to deploy this component. So this is still under discussion. Recently, Ministry of Health has endorsed the EMR guidelines, and hopefully it will come up as the next deliverable. The last component is the point of services, where we provide the care, where we collect the data, and we try to engage with the upper tier that is mentioned. So there are a few challenges. As I mentioned, national ID and client registry is not in the place. National ID is there, but is not being used for all of these reasons are not enrolled yet. So we can't think about the health ID for now. But eventually that has to be mapped on with the health ID as the functional ID. So national ID refers to the civic identification, whereas health ID refers to the functional ID, where clinical data is to be mapped. So shared health record is the another component, and terminology standards are the challenges. Here I'm mostly focused with the national ID or health ID because that's the foremost requirement when we think to share the information within the providers or within the healthcare institutions. So these are the usability, and these are the crucial infrastructure that has to be placed forefront, but not only the application. Only the application will not solve the problem. So these are the very basic groundwork that is totally dependent with the further digital health innovation. So I'm concluding my presentation. So if there are any questions, just feel free to ask. I'm here. Just note my email or phone number. Thank you.
So any query to Mr. Sanjay Paudel? confidentiality को के issue हुन्छ Mr. Sanjay, so is there any issue about like patient confidentiality in this record when you are like transferring record from one institution to another?
Till now, digitally we haven't been able to do that. So for that, we are also waiting for the national digital data sharing policy. So
okay. Yeah, I think there is no such policy as such.
Yeah, we are waiting for that. Until and unless the policy is not there, the national data sharing policy is not there, we won't be able to gather the requirement or fulfill the ask of data safety and privacy. So for now, we have the manual process, we have the policy is there, but that only gathers the manual data, not for the digital data.
Okay. Any other query? So thank you, Mr. Sanjay Paudel. So we'll move ahead with the next presentation. It's from Dr. Anaya Singh Chauhan and Dr. Sonakshi Sharma. They were not able to introduce earlier. So Dr. Ananya Chauhan is the first year medical student at the University of Nevada, Reno School of Medicine, with the background in cancer clinical research, and Dr. Sonakshi likewise is a medical student at the Penn State College of Medicine, who is currently completing a research fellowship in at National Institute of Health. They will be presenting on strategies to improve cancer screening in the rural setting. Please go ahead, doctors.
Thank you so much for your kind introduction. I'm just going to share my slides.
Oh. MS1, MS4 on the right side.
Sorry. Okay, alrighty. So as everyone already introduced us, my name is Ananya Chauhan. I'm a first-year medical student at the University of Nevada, and we will be talking about strategies to improve cancer screenings in rural settings. And I would like to thank my colleague Sonakshi Sharma from the Penn State College of Medicine for assisting me with these slides. So just a general outline of what we'll be talking about today. I'll start with a little background, move into current screening strategies in rural Asia, some challenges in implementing these screening ideas, and innovations and strategies to help each challenge, following with some concluding thoughts. So 90% of global rural populations live in Asia and Africa, with over half of these living in just India and China alone. And individuals in rural communities of Asian countries with cancer have higher incidence rates and consistently higher mortality rates than those in urban areas. Both these graphs on the bottom kind of represent what I've just said. On the left-hand side is the global health burden of lung cancer, and on the right-hand side is the global health burden of colorectal cancer. And what we can see is both are highly densely populated in Asia. This goes to show that it's not specifically a genetic predisposition that is leading to the high health burdens of cancer in these areas, but lack of access to proper health care, preventative care, and screening innovation. Asia accounts for roughly half of global cancer incidence as of 2020. And as of WHO's Global Cancer Observatory of 2022, the 5-year prevalent cases were over 23 million, the number of new cases were almost 10 million, and the top 3 leading cancers by incidence were lung, breast, colorectal. I think it's also important to note here that the top 3 leading cancers by mortality in males was lung, liver, and stomach, and in females was lung, breast, and cervix. It's important to note that breast, cervix, and oral cancer are all preventable diseases. I think on the graph on the right here depicts the gap between urban and rural screening strategies very clearly. The orange line on top is cervical cancer screening rates in urban areas, while the green line on the bottom is cervical cancer screening rates in rural areas. And we see this large gap between the two, again emphasizing the lack of access and healthcare infrastructure in rural areas. The WHO in the late 1990s created guidelines on how to make a national cancer control program, which many countries have adopted. India, Sri Lanka, Afghanistan, Bhutan, and Maldives are some of these countries. India has actually had an NCCP since 1975 with the goal to reduce cancer morbidity and mortality and increase accessibility to cancer screening, prevention, and treatment in rural and remote communities. Since then, they've made some headway. They were able to establish a cancer registry, develop cancer care centers and oncology medical programs to better train healthcare professionals. They've been able to implement tobacco control policies at the national level, improve access to screening and treatment services via rural clinics, and overall improve screening rates. These other countries also have similar positive outcomes. While Nepal doesn't have an NCCP specifically, they have a very similar program, the Multi-Sectoral Action Plan for Prevention and Control of Non-Communicable Diseases. The goal of this program is to prevent and control non-communicable diseases and reduce suffering and premature mortality while improving the quality of life of the people of Nepal. Their goals overall with this program is to expand the cancer registry, train healthcare workers to improve screening infrastructure, expand screening programs into rural and remote areas, use mobile health clinics to reach remote populations, and overall raise awareness through public health campaigns and improve the education on cancer screenings in all their populations. China also has multiple programs, one of which is the National Cervical and Breast Cancer Screening Program, which is part of their larger initiative for Healthy China 2030. The goal of this program specifically is to offer free cervical and breast cancer screening for rural women. And so far, the results have shown significantly increased screening coverage, and the current trajectory plans for reaching 90% coverage by the year 2030. The graph on the right here kind of depicts not specifically this program, but in general, their rural cancer screening facilities throughout their country. The red dots represent rural screening areas, facilities, and the green dots urban facilities. And what we see is there's a good half and half between both types of facilities in both areas. We do see also all these dots highly concentrated where there are more people. There are still some gaps to fill, but we're all moving in the right direction. So what are some challenges in implementing all these screening procedures that the government and national ministries of health have set forward? One are cultural. The participation in multiple unhealthy lifestyle behaviors such as using tobacco and smoking, women feeling uncomfortable with certain testing, especially with the lack of these facilities. There's also the lack of female providers in these rural areas, and many women feel uncomfortable going to male providers for the more sensitive testing. Often for women, breast cancer and cervical cancer are the two types of screening that we do. So that is for sure a large barrier. Another is socioeconomic barriers, lower literacy in rural and remote areas, societal and cultural gender roles and associated stigmas, and then cultural health norms. This can include the practice of herbal medicine or Ayurveda in India, and both these practices may not emphasize the importance of cancer screening, and it always people who practice these kinds of healthcare usually feel nervous or uncertain following Western practices of cancer screening. There's also technological difficulties. This includes difficulty to preserve and transport samples from rural and remote areas, as well as a lack of infrastructure to have screening facilities. An example of this is having a mammography suite. To be able to run a mammography suite, you need to have constant electricity and power. You have to be able to have the capacity to store multiple images, and then also a radiologist on hand to analyze those images. And sometimes having consistent electricity is not always possible in more of the rural areas. These are a few pictures that Ms. Sonakshi saw when she visited Nepal herself. On the left is a clinic with very little pharmacy capabilities. On the right-hand side is a picture of an exam room within that clinic, and the center is a lab that was run by had one analyst specifically, whose job was to collect and analyze by hand each of the screening samples that were collected, which is a very high workload burden on one individual and can be prone to error. The last challenge that we wanted to point out were more healthcare-based challenges. There's unfortunately a lack of trained healthcare professionals in these rural and remote areas, lack of general practitioners to educate patients of cancer screening guidelines. For the general practitioners that are there, there's very limited consultation time in family practice, and there's also just a lack of healthcare coordination for follow-up. So what are some innovations and strategies? Many community-based programs aim to improve knowledge and attitudes towards screening. India's mobile cervical cancer program for rural India created educational materials in multiple languages with imagery to be accessible at different literacy levels. And what we saw was that education prior to screening helped improve screening levels by making individuals feel more comfortable before entering the process. China's All China Women's Federation has worked with the Ministry of Health for the Two Cancers Examination Project, which provided free screening for rural women and involved publicity, health education, and exams. Also, the expansion of AI, communication and internet capabilities, and general advancements in technology provide a new frontier for cancer screening strategies. China has been using the landing program, or the landing device, which is a handheld automated scanner that can be used anywhere there's 4G mobile communication technology to perform cytological and histopathological diagnoses for cervical cancer. Using liquid biopsy. It's low cost, high quality, provides quick results, increases access, and has improved in our screening numbers. Unfortunately, there's still the challenge of working through a high load of negative cases and making sure they truly are negative. So it's not perfect, but we're working again in the right direction. India also has the Mobile Technology for Cancer Screening, or mHealth. In this program, they train community health workers with mobile devices, increasing their confidence in the care that they give in these rural and remote areas. They're able to collect data in real time and report it. They also get step-by-step guidance through the mobile device, and it allows physicians in urban settings to remotely review screening results. They also have the AI-based thermolytics device for breast cancer screening. It analyzes thermal scans to estimate likelihood for breast malignancy. It's more objective than India's current standard of clinical exams and has a low cost, is radiation free, and community health workers can be trained and can easily use it. The challenge with this one is that it is very sensitive, so there's a lot of false positives that go along with this technology right now. The last thing I want to talk about is healthcare-based innovations and strategies. Many countries have existing programs that can be leveraged to incorporate more holistic primary care services. For example, India's Ayushman Bharat program can be used to implement healthcare facilities equipped for cancer screening and prevention. Additionally, with so many community health workers and government programs already in place, it's important to collaborate with the existing healthcare system to provide interdisciplinary care. For example, in Nepal, there are community health workers that work specifically in the sex worker community, educating them about HIV and helping them get medication and treatment. It's easy in this situation to also include cervical cancer screening, testing, and resources, as having multiple sexual partners is also a risk for cervical cancer. Physicians are also in a place where they can help educate and provide patients a safe environment in which stigmas held against screening procedures can be worked through. Some of these stigmas include screening-induced bodily discomfort, fears of physical harm, embarrassment, apprehension, or fear of results. And doctors hold a very respected place in our society where they can provide this safe environment to work through with patients, help educate them, and make sure that they feel comfortable and understand the cost and benefit of each screening procedure and why they're important. So I think it's really important that we leverage that kind of benefit that they hold to society and help our patients feel more safe. So what are some key findings that we found from our research? Rural communities face higher cancer mortality due to limited access to screening, and cultural, technological, and healthcare-related barriers hinder these screening efforts. Existing national programs have made progress but require further expansion and refinement. So where do we go from here? Culturally, we can include community education, stigma reduction, and gender-sensitive approaches. We can use technological advancements such as AI-driven screening tools, mobile health clinics, and real-time data collection. And we can train community health workers and integrate into existing programs to help improve cancer screening rates. Overall, our goals should be to strengthen interdisciplinary collaboration, expand scalable and cost-effective screening methods, and advocate for policies that enhance rural healthcare infrastructure. I think it's important to remember through all of this that early detection does save lives. So by addressing these barriers and leveraging the innovation, we can bridge the gap in rural cancer screening and hopefully reduce the cancer burden in Asian rural communities. Some acknowledgements, and thank you all for your time.
Thank you, Dr. Ananya Singh, for your wonderful presentation. So, for the audience, if any query for our presentation? How about the financial challenges? Like, I think most of the screening program you mentioned, most of them are usually like grants and like funds, right? So how do you think we can cope with that? Like, usually in a country like us, Nepal, India, in the remote place, where it's very difficult to expensive for all the screening in future. What's your thought on that?
So I didn't get to talk enough about socioeconomic barriers. I brought it up in the cultural barriers section. I know a lot of these programs, especially the free programs in China and India, are fully government funded. And I know government funding is not huge, right? Like, it's not like never ending. Unfortunately, there's allocations. And I think for now, just because in these rural and remote areas, they are usually lower socioeconomic status, so they do have difficulty with transportation or getting to these places, using grants is probably the main way to go about it, and government funding. To at least help get it started, and then also working through insurance. I know I didn't include it in this specific what's it called, PowerPoint, but when I was researching, I did notice in countries like Indonesia and Singapore, their health insurance, both national and private insurances, are able to cut those costs down a little bit for the patient. So for certain age groups or people who are on maybe government insurance, a lot of these tests are covered by that insurance, whereas for areas that have more private sector insurance, they get discounts through certain programs depending on age or health, like current morbidity and stuff like that.
Thank you. So, any further questions? So, we'll be moving to our last presentation for this session. Ms. Kanchan Gautam will be talking about psychological aspect of cancer patient in rural healthcare. Ms. Kanchan, you can...
Thank you very much. Thank you very much, sir. Good afternoon to everyone. Am I audible?
Yes, Ms. Kanchan, you are audible. You can go ahead.
Good afternoon to everyone. It is a matter of great pleasure and honor to be speaking in the presence of distinguished personalities at the 59th meeting of APAN Rural Health Care Session. My name is Kanchan Gautam and I'm working as a psychologist and social counselor. The topic of my presentation is psychological aspect of cancer patient in rural health care. As we all know, cancer is a significant global health burden affecting millions of people worldwide. Beyond the physical toll, it profoundly impacts mental and emotional well-being of the patient and also the family members. Individuals in rural areas face unique challenges in accessing cancer care, including limited healthcare infrastructure.
Excuse me, Ms. Kanchan, can you share your PowerPoint? You are not sharing it.
Okay.
Okay, we can see it now.
Okay. Is it visible?
Yes, it is. Yes.
Okay. So individuals in rural area face unique challenges in accessing the cancer care, including limited healthcare infrastructure, financial constraints, and the influence of cultural beliefs on health-seeking behavior. So this presentation explores the psychological aspects of cancer patients, especially within the rural context of Nepal, highlighting the unique factors that influence their experiences and proposing potential intervention accordingly. The data on cancer prevalence and mortality in rural Nepal is often limited due to the challenges in data collection. However, it is recognized that cancer is a growing concern in these communities. The cultural beliefs about illness causation, traditional healing practices, and the role of family in caregiving significantly influence how individuals in rural Nepal perceive and respond to cancer diagnosis. The rural healthcare in Nepal often has limited access to specialized cancer care, unlike the urban area of Nepal. Hospitals with oncology departments, chemotherapy, radiotherapy facilities are often concentrated in urban centers, posing significant logistical challenges for rural patients. Similarly, palliative care services are scarce as compared to urban areas in the rural part of Nepal. As mentioned before, research on the psychological state of cancer patients in rural Nepal is very limited, and the studies in similar setting indicate a high prevalence of depression, anxiety, and other various mental health condition among this population. And the psychological challenges commonly experienced by cancer patients includes emotional distress, which includes anxiety, fear, depression, sadness, anger, and the feeling of isolation. The cognitive difficulties include memory problems, impaired decision making, difficulty concentrating, behavioral changes, which include social withdrawal, irritability, sleep disturbances, and so on. Some of the factors that exacerbates or amplifies the factors of mental health issues in cancer patient in rural setting of Nepal includes the scarce access to mental health professionals specializing in oncology care, which is very common, and the geographic isolation of that place, limited community resources, and a lack of cancer support groups. Similarly, the social stigma associated with cancer can lead to isolation and hinders access to care, and also hinders the health-seeking behavior of the patient. Lastly, the high treatment cost, travel expenses, and loss of income due to illness poses the financial difficulties, and it also causes the mental health issues. These are some of the cultural and socioeconomic factors that increases the mental health issues in the cancer patient in rural Nepal. So the integration of traditional healing practices alongside conventional medicine is quite common, and it requires culturally sensitive approaches. The family plays a central role in medical decision, impacting individual autonomy and their decision making. The gender roles influence coping mechanism and access to care, which hinders the health-seeking behavior of women, and women face additional burdens because of that. Poverty restricts access to nutritious food, transportation, and adequate housing, impacting overall well-being of the patient. Similarly, the social stigma, which is very common, related to cancer can lead to social isolation and hinders health-seeking behavior of the patient. So these are some of the recommendation and intervention that can be taken into consideration to alleviate the mental health issue and improve the mental health status of the cancer patient in rural part of Nepal. Firstly, integrating mental health services into existing cancer care pathways in rural areas would be very helpful. Similarly, training healthcare professionals to recognize and address psychological distress in cancer patients in the initial stages, and utilizing community health workers, establishing peer support groups to provide psychosocial support, developing culturally appropriate educational materials, addressing cancer misconception, and promoting mental well-being. And lastly, implementing strategies to reduce financial barriers to accessing cancer care and mental health services can be very helpful to improve the mental health status of the cancer patient in rural health settings. Addressing the psychological well-being of cancer patients in rural Nepal is very important for improving their overall quality of life. Mental health is an important part of cancer care and should be given equal importance as much as physical treatment. More intensive research is needed to understand the specific psychological needs of this population and to develop effective intervention, and increased resources and support are essential to improve the lives of cancer patients in rural part of Nepal. Thank you very much for your time. Have a great time ahead.
Thank you, thank you, Ms. Kanchan. So, anybody has a query with Ms. for Ms. Kanchan? So, let me ask you this. So, like you mentioned in your presentation, like in country like maybe in Nepal, it's very common. It's if if some member of the family is diagnosed as a cancer, the treatment is usually family oriented, like you mentioned. So the family doesn't want the patient that they have a cancer, right? So because of all the psychological and anxiety and all those things. So you being a psychologist, what are your thoughts? Like, should a patient be informed about their cancer diagnosis? Because we see lots of like family members, they like patient is under completed the treatment already, but the patient doesn't know that he or she has a cancer. So as a psychologist, what's your view on this?
I think a patient should be informed about the diagnosis, and uh, any and if whenever they know about the diagnosis, their fear, apprehension should be addressed by the psychologist and doctor, and it is very very essential for them to know about the diagnosis in the first place.
Okay. So if there is no further question, so we have come to the end of this wonderful presentation, wonderful session on rural healthcare session. So before we end, we'd like to hear some from first from Professor Moriyama. So your thoughts on today's session and few words. Behind the side. So I think he left already. So Dr. Rosni Amati is there also at the venue. So I'd like to also hear her, like if there is some words from Dr. Rosni about today's session.
Thank you so much. Like listening to the papers presented over here, I was very much impressed the work you have all done. And as I'm also working in the rural health, I also gained some ideas on how we are working, and like it is similar in Nepal and in Asian countries. Like the problem is about the rural areas, about the transportation, and so we could learn from your papers also, your presentations also. And thank you so much for that. Thank you.
Thank you, so for the end, I'd like to request Dr. Uday Koirala to give a closing remarks.
Yeah, thank you. So all the presenters, it was very nice presented, and as our theme is cancer care in rural health setting. So actually, it was to increase the awareness about cancer in rural healthcare. Of course, there is always the insufficient work, and we have to do a lot of work in policy making, in care, in psychological aspects, and different aspects of cancer care. It should be a comprehensive cancer care in rural healthcare setting. So that is, I think it has raised the awareness, and since the time is already too late in the venue, so I think most of the venue who are there, present there, are already has left the venue. So I think it was a nice presentation, and we'll meet again. I think it was the last day, and APAN must have gone very well. So thank you all.
Thank you. So this is the end of the session. Also, I'd like to thank our engineer. Without them, this wouldn't have been successful. Mr. Rosen and Nirajan. Hi, Nirajan, yeah.
Okay. Thank you everyone.
So we'll see you in our next APAN 60. So have a great evening. We'll see you soon. Thank you.